there is a debate, first of all, regarding the pre-transplant treatment in higher risk MDS. I tried during my presentation to answer three questions. First of all, do we need really a pre-transplant debulking treatment? Actually, I'm not sure that we need really to change, to add, a pre-transplant treatment. Why? Because the impact of pre-transplant on post-transplant, it's not clear. And we did this big retrospective study at the Chronic Malignancy Smoking Party of EBMT, trying to see if any change in the IPSS of the patient at diagnosing and at transplantation can impact the outcome, post-transplantation outcome. Actually, we didn't find any difference because we broke down the patient into three categories. Patient who improved their RIPSS between diagnosis and transplantation, patient who kept the same RIPSS between the diagnosis and transplantation, and patient who progressed before transplantation. At the end, we had absolutely the same overall survival and evidence-free survival for the three of them. And our conclusion, our guess that outcome post-transplantation, it's more related to the biology of the disease rather than the disease status itself before transplantation. So for us, this first question, probably we don't need if we can do a transplantation within 2, 3, or 4 months, which is something really reasonable for the time being nowadays. So we can go right away for transplantation, and we can work on treatment or strategies post-transplant. The second question, especially for the new drugs, of course, now we have targeted drugs, or molecules, so we can target IDH1, IDH2, for instance, and we can maybe impact the effect of TP53 mutations. And we have this association between Venetoclax and Azacitidine. So we have many new drugs, and we have better results than we used to have with the old drugs or old-fashioned drugs, I would say. However, we don't have any solid data for now to recommend them as a standard of care before transplantations. I would say, first of all, what we need before transplantation, it's really to bring the patient into CR, and even with the new drugs, the CR rate is something like 30, 40, or in the best case, 50% of patients. So we are far from achieving our goal to transplant the patients in CR. First of all. Secondly, there is some toxicity, and we need to keep this in mind. And we are still lacking prospective randomized study. So I think for the time being, it's difficult to recommend the new drugs as the standard of care before transplantation in patients with higher risk MDS. However, you can discuss this case by case, and we need more, I would say, data to really have a good view on what we can do for those patients to improve outcomes. Now, can we use these new drugs post-transplant? I think yes, we need really to investigate these new drugs and post-transplant. Of course, we cannot apply the same treatment for everybody because just if I can give you an example for IDH1, IDH2 mutation, so we can observe this in a small subset, 5 to 10% of patients. So we cannot offer this to all patients. And TP53 is it can be at 15% of patients, but half of those patients have complex karyotype and so on. Maybe the association between with Azacitidine and Venetoclax can be investigated, and I think for the time being. This is a good combination to be investigated post-transplant.